Thanks for the patience as we work through that. Really a pleasure to be joining you today. I'll begin with just an overarching comment, which is I'm greatly appreciative of everything everybody's doing through the COVID-19 response as we continue to care for our patients, and the ways and the manner in which you're continuing to do that and conduct yourselves, I'm just extremely proud of. The teamwork is wonderful. The resilience is great to see. And I'm just looking forward to when we can all be together in person. But in the interim, I'm thankful for the opportunity to connect in this way. And I wanted to also extend my thanks to Gabby for bringing us this venue. The topic for today is to talk about something which we all know quite a bit. It's very fundamental to being being a provider in cardiovascular medicine, and it's the cardiovascular evaluation of the patient undergoing non-cardiac surgery. But there's a lot new in this field, and a lot has happened since the last guidelines were published in 2014, 6 years ago. And so I really want to take us today through this idea, moving from risk assessment to the idea of surveillance, and describe what I think are some of the best practices in 2020. So in terms of an outline, we'll talk about traditional approaches to pre-op risk stratification and some newer methods such as the NSQIP. I'll define what that is. I'd like to identify some subsets for you that are at high risk that we cluster in our centers, such as aortic stenosis and pulmonary hypertension. I'm going to spend quite a bit of time on using biomarker monitoring in the postoperative period for the optimization of outcome detection and explain to you what's new there. And that's where a lot of the new evidence is. And then we'll talk a lot about evidence-based approaches to medication management, including anticoagulants, beta blockers, and statins to optimize patient outcomes. To begin with the magnitude of the problem, in a 2004 modeling project, it was anticipated that each year, 4% of the world's population would undergo a non-cardiac surgery. And about a third of those are extensive procedures that occur in the setting of some cardiovascular comorbidities. And this is a growing, each year by year, the rates of non-cardiac surgery increases. The overall complication rate from non-cardiac surgery is about 7 to 11%. And the mortality is anywhere up to 1.5%, with a little less than half being due to cardiac causes. So the complications, while infrequent in these common surgeries, are often cardiac. So when we're consulted on these patients because of concern for cardiac morbidity that could occur with a non-cardiac surgery, that's the reason. But we do this in a changing demography. Patients are older. There is better cardiac survivorship. As we all know, more patients are living with cardiac problems. And there is at the same time a declining level of non-cardiac surgical risk. We're both more prevalent in the risk of the population undergoing surgery, non-cardiac surgery, yet overall surgery is viewed to be becoming safer and safer all the time. And so some of the approaches we developed in the 1990s, such as the RCRI, or the Revised Cardiac Risk Index, I think are called into question today. So the surgical risk assessment really assumes a few things. One is that you're dealing with a stable patient without active cardiovascular disease. The patient with active cardiovascular symptoms, and that is a lot of what we do when we evaluate these patients, is we surveil for, do you have an independent cardiac problem that needs to be addressed outside of the need for non-cardiac surgery risk assessment? That's really should not be present, so the patient should be stable. And then what we're thinking about when we think about surgical risk assessment is what's the near-term risk, the 30-day risk of cardiovascular death and MI. A few principles, and one of which is that low-risk surgery should proceed without further testing. A snip from the European Society guidelines defining what's viewed to be low-risk surgeries there on the far left, below 1%. Like superficial surgeries, breast exams, dental, ocular surgeries, asymptomatic carotid surgeries, and minor urologic and orthopedic procedures. When it's not a low-risk surgery, we are often asked to think about the risk. And in 1999, the RCRI was put forth. This is the revised cardiovascular risk index, which proceeded from the original risk index put together by Lee and Goldman. And it uses 6 predictors of complications of cardiac risk of non-cardiac surgery. And you're seeing them there on the right. They are the history of ischemic heart disease, a history of CHF, history of cerebrovascular disease, either stroke or TIA, diabetes requiring preoperative insulin use, CKD defined as a creatinine greater than 2, and if there were certain types of surgery such as suprainguinal vascular intraperitoneal or intrathoracic surgery. And those 6 factors were used to predict 5 principal cardiovascular outcomes, which included MI, VFib, cardiac arrest, complete heart block, and pulmonary edema. Note that mortality is not on this list. And a patient with 0 or 1 predictors would be considered low risk, and those with 2 or more would be considered high risk. And that's present in about 1 in 5 patients. 1 in 5 patients going through surgeries in a contemporaneous analysis would be considered high risk, that is having 2 or more of these factors, recognizing that these factors are becoming more and more common. You know, the prevalence of ischemic heart disease, heart failure, diabetes, and so forth is just becoming greater and greater in our population. So the RCRI is simple to apply. These are easy to identify factors. They're done with a fair amount of consistency from provider to provider. And it does predict meaningful, although not all meaningful, cardiovascular outcomes. Here's an example of a screenshot. You can do these calculators online. Here, a patient with none of these factors would be considered low risk and have a 0.4% risk of a major cardiac event. So the risk for adverse cardiovascular outcomes increases with the number of factors, and the risk exceeds 1% of it having an adverse cardiovascular outcome when an RCRI is greater than or equal to 2. And that's the threshold that many guidelines will point to when additional testing or screening or thinking about the patient is necessary. But as we apply the RCRI, there's a few limitations. One is it's cardiac events only. In other words, there's a host of other events, as you'll see in a moment, that this does not cover at all. Its positive predictive value is quite low. If you look at the table below, this is an external analysis of the predictive value of the rates of cardiac death, non-fatal MI, non-fatal cardiac arrest, according to the number of predictors. And if you're 2 or more factors, two risk factors, it's a 2.4% risk, meaning 97.6% of patients will get through surgery without an event. And 3 or more is still only 5.4%. And these rates are felt to be going down over time. That is, surgery is safer and safer with modern anesthetic techniques and so forth. So it's a starting point, but it's really now 20 years old. So there are newer risk models out there, and there was one called some refer to it as the Gupta index or the MICA index, the MI and cardiac arrest index. And is now morphed into what is called the ACS NSQIP. This was developed by the American College of Surgery and comes out of the National Surgical Quality Improvement Project. And it encompasses 21 predictors of risks for major cardiac complications. So it's far more inclusive than the RCRI. And they created this prediction rule in 2011 in over 500 US hospitals. And it continues to accrue data, day by day, and now has over 1.4 million operations included that have developed the prediction rule. Now, keep in mind the derivation and the validation sets of the RCRI included fewer than 4,000 patients. And so think of that: 4% of the world's population has a surgery, non-cardiac surgery every year, and we're using a risk tool, RCRI, that was developed in 4,000 patients. Now, when evaluated, this NSQIP risk calculator, as I'll show you in a moment, actually outperforms the RCRI, and it calculates a host of outcomes, not just major adverse cardiovascular events, but also death, overall death, pneumonia, venous thromboembolism, acute renal failure, returning to the OR, and so forth. It also predicts length of stay. And this is it. You can, again, do this online. It's at the facs.org website. And you go to this site and you enter the data, and it'll predict, as I'll show you in a moment, it gives you an output of what the actual event risks are. Now, one thing is that is very specific to the procedure, whereas the RCRI uses that low, intermediate, and high risk procedure in terms of how they're applied. This is very procedure specific, and you actually put in the specific CPT code. That's one of the strengths of having over 1 million surgeries that inform this. And then you enter all the risk factors as shown here, which overlap quite a bit with the RCRI, but go well beyond the RCRI. And it comes out with output that looks like this. And so this is a patient, you see in the blue at the top, a patient undergoing surgical laparoscopy with colectomy and anastomosis. And the risk factors are that the patient is under age 65, is male, is ASA3, is diabetes on oral agents, and is hypertension and obese. Those are the factors that I put in. A typical middle-aged diabetic patient with hypertension undergoing a fairly common surgery. And you can see here that the outcomes predicted are shown on the left, and on the right, it shows the estimated patient risk, and then whether that outcome is above or below average for a patient for that surgery. So a serious complication risk you see is 6%. Any complication is 13%. On the fourth line there, you see cardiac complications is 1%. And it includes other outcomes such as surgical site infections, venous thromboembolism, renal failure, return to the operating room, overall death, or discharge to nursing facility. And you see at the very bottom, predicted length of stay is 3.5 days. What I like about this is it puts cardiac risk in perspective. It is both cardiac risk, plus it places in the context of what the overall risk of the patient is. For example, the risk of death is less than 1%, cardiac complication is 1%, but any complication is 13%. So cardiac complications represent really less than 1 in 10 of the potential outcomes this patient could face. And it often is good for putting context of our recommendations against overall recommendations for the patient undergoing non-cardiac surgery. And so this is a side-by-side of the RCRI and then the NSQIP calculator and the factors it considers. And you can see that the NSQIP is much more robust. And while there's overlap of those top 6, and what's in the RCRI is in the NSQIP in large extent, there is much more there. And so there have been some direct comparisons of these different risk calculators. And here's one of a comparison of these risk tools in 663 patients who had an overall event rate of 2.1%. And they basically said that all tools accurately identify low risk. And you see in the graph there that in terms of the proportion of patients with actual events on the vertical axis that were considered low risk by these cardiac risk calculators, they all identify the low risk patient. They also all identify the high risk patient. But when considered in terms of overall accuracy using area under the curve, it was the NSQIP that had the highest accuracy for overall event prediction. But you'll also continue to see that the overall positive predictive value is low. That is, the proportion, if a patient was high risk, still only about 15 to 20% actually have an event. So most do not have an event. And that remains a problem, is that the positive predictive value of these tools is quite low, which really begs the question, if a patient is not low risk, that is, they are higher risk, really what should we be doing for that patient to identify how to best get them through surgery and to monitor them? So most recommendations that are written about these tools suggest doing more than one, saying they are complementary. The NSQIP is more accurate, particularly for death. It doesn't include some outcomes that RCR includes, like pulmonary edema and heart block. And the RCRI discriminates moderately well for low versus high risk, but it doesn't include death. So doing both has some value. But again, they identify low risk, and the positive predictive value for both is low. So we move on to diagnostic testing. And I'm not going to dwell on diagnostic testing because I, in fact, think that it is a vestige of the past, but I will, for I'll, for the sake of completeness, give you one slide on what I think where diagnostic testing is right now in terms of guidelines. ECGs are, after you do these risk indices, an ECG is only done in patients with risk factors and intermediate to high risk surgery to serve as a baseline. Cardiac ultrasound is not routinely recommended, but important findings when suspected clinically are shown there that could include LV dysfunction, significant degrees of mitral regurgitation, or increased aortic valve gradients, or stenosis. And last, ischemia testing, which has been vastly overused through the past, has shown a few things. Well, first is that just like low-risk patients are indeed low risk by the scoring tools, normal scans in patients who undergo ischemia testing have an excellent prognosis. The positive scans are only meaningful when there's a significantly high burden of ischemia. And indeed, even with these tests, the positive predictive value has decreased over time, much in the same way as it has for the various clinical risk indices. And so at the current time, the only class 1 recommendation for imaging stress testing is before a high-risk surgery in patients with more than 2 clinical risk factors and who have poor functional capacity. And all other indications for stress testing prior to non-cardiac surgery are either a 2B or a class 3 recommendation. So in large part, not recommended. What's commonly resorted to is simply functional assessments on assessments of functional capacity. And everybody knows it's sort of that 4 MET threshold. Seen on the left there is, can you, and everyone's got their favorite question here, climb a flight of stairs carrying a few bags of groceries, or climb 2 flights of stairs or walk up a hill. And if you can do that, you can generally felt that you can attain 4 METs of activity. And it's felt that when functional capacity is high, meaning more than 4 METs, prognosis is generally quite good. Recently, though, that's been called into question. And a study called the METS study, published 2 years ago in Lancet, actually looked at how clinicians assessed functional capacity using these estimated METs. And they looked at actually what patients could actually do in terms of peak oxygen consumption. And you see on the right in that graph that there was, in fact, quite a bit of overlap and really no good discriminating power for assessing a patient having poor functional capacity subjectively or having good functional capacity subjectively, suggesting that in doing this MET estimation clinically, we're really missing it most of the time. Subjective assessment had a 19% sensitivity for identifying the inability to attain 4 METs. There is a validated index called the DAISY score. It's a Duke Activity Score Index that was associated with predicting the primary outcome in this study, which was, again, a poor measured oxygen consumption. But we don't routinely do DAISYs in clinical tests in clinical medicine. And in fact, even it is, again, subjected to the issue of poor positive predictive value. Stress testing, just to dive into a little bit further, just to prove the point, is really been overdone. And this is a study from Ontario where much of this work has come from Canada in the Canadian health system on preoperative testing. And in a 10-year sampling window in a propensity cohort matched analysis, patients undergoing intermediate or high-risk non-cardiac surgical procedures, about 9% underwent stress testing. And the outcomes were that overall there was no effect. There was a hazard ratio of 0.92 with a confidence interval extending all the way up to 0.99 for survival, with some excess rates of cardiac catheterization and revascularization. And if you look in the bottom, that forest plot under the RCRI index classifications, actually there was net harm in patients who had a low, meaning 0 RCRI. If patients had a higher RCRI, particularly 3 and above, stress testing did appear to help in terms of overall survival. But you see the curve at the top right there, and this is the survival curve for this propensity matched analysis of 46,000 patients undergoing stress testing versus no stress testing. And in fact, out to 30 days, there's in fact no separation of the proportions that were dead during follow-up. And it's only over time, and it's actually quite negligible effect over the first year, whether stress testing or no stress testing survive. So stress testing really should be quite infrequent it should be limited to patients who have a high RCRI and has few clinical implications, which really derive from the fact that when looking at where does stress testing actually lead you, it doesn't lead you anywhere typically productive. The CARP study, the coronary artery revascularization study, was a study of vascular surgery patients, now published 16 years ago, and patients were randomized to cath and then revascularization as appropriate prior to that major vascular surgery. And at 2.7 years, there was no difference in overall outcomes for the catheterization versus the no catheterization group based on revascularization status, such that there really isn't any benefit to revascularization prior to non-cardiac vascular, major elective vascular surgery. And so this really began to put the dampers on stress testing and routine cardiac imaging and catheterization prior to major surgeries such as vascular surgery. So if stress testing and invasive testing doesn't really lead you anywhere, maybe we should just treat medical risk medically. That is, optimize the patient's risk as assessed by the risk indices by the use of certain medications which could mitigate any excess risk, say, of an increased RCRI or an increased NSQIP score or low functional capacity. And this has been looked at in a variety of ways, particularly for beta blockers, statins, and aspirin, and we'll go through those in detail. Beta blockers, I have to say, in my career, I've seen beta blockers in preoperative risk come, go, and then come back a little bit, but with caution. They were all the rage in the late 90s because of some studies, such as the decrease study that suggested that beta blockers mortality quite significantly in non-cardiac surgery. Those studies, though, have a question as to their science and integrity. And a subsequent study called POISE and Integrity 1 looked at patients with history of CAD, PVD, or stroke who were undergoing major vascular surgery and had CAD or one of multiple risk factors, and they were randomized to an aggressive approach to the use of metoprolol versus placebo, with metoprolol beginning, as you see there on the right, based on certain preoperative heart rate and blood pressure parameters, and with a preoperative dose given 2 to 4 hours pre-op of 100 milligrams of metoprolol orally, quite a big initial dose, and then continued post-operatively, including substitution of IV if necessary. And what POISE 1 showed is seen here, is that the overall composite outcome was marginally significant for favoring metoprolol over placebo, and there was a double-edged sword. That is, total mortality was higher in the metoprolol group there, about 1/3 of the way down in that table under secondary outcomes. Total mortality 3.1 in metoprolol versus 2.3 in placebo, but there was a slight reduction in myocardial infarction, as well as in myocardial infarction rates at the expense of a significantly more hypotension and bradycardia, as you would expect, and a significantly higher stroke risk. So it really is quite a double-edged sword, and this was a high-risk group of patients. This is indeed the 30-day death rate, with placebo group seen in purple and the metoprolol group seen in green. This has been then subject to additional analyses, and this was a UK-based study of over 660,000 operations performed in a similar time frame as POISE 1, with over 122,000 receiving beta blockers. Again, this had become quite the rage after some of these early studies done in the 90s. And overall, you see in this propensity match cohort study that, in fact, in the top right there, you see that actually patients with RCRI scores of 0 or 1 were in fact net harmed by beta blockers. And only in the RCRI 3 and 4 groups was there a benefit seen for overall in-hospital death rates. Again, and this was in patients undergoing major non-cardiac surgery. So there's really a cautionary tale here in that there is potential harm of indiscriminate beta blocker use. There is a double-edged sword of mortality against other event prevention and adverse effects, and it's confined, if benefit is there, it's confined to, again, the highest risk groups. Such that in 2014, the ACC/AHA revisited their guidelines and basically stated the following in a systematic review of the beta blocker use. That is that beta blockers overall decrease non-fatal MI, but increase stroke, hypotension, and bradycardia with a trend towards increased cardiovascular mortality, leading to the following summary recommendations on the use of beta blockers, which is first, the only class 1 recommendation, and these are the ESC guidelines from 2014, are that if a patient's on a beta blocker, they should stay on a beta blocker. Discontinuation of beta blockers actually is associated with a 4-fold increased mortality risk because of the withdrawal of beta blockers at a time when there may be surges of adrenergic tone. Otherwise, all recommendations for beta blockers are class 2B or 3. Beta blockers should not be started preoperatively without a strong indication. They should not be started immediately preoperatively. That was a strategy used in POISE 1. And if begun, they should be done as far preoperatively as possible. So beta blockers have kind of come and gone, and they're back again a little bit. What about statins? And statins, while ubiquitous, are never as ubiquitous as they could be. And there are some randomized data on whether statins reduce cardiovascular endpoints. This is probably of this, although small, one of the better studies on the topic, which was performed in statin-naive patients undergoing elective vascular surgery and randomized patients to high-dose fluvastatin versus placebo. And a fluvastatin 40 milligrams will be equivalent to about 20 milligrams of atorvastatin. It was begun a month preoperatively, and that's an important point to make. Not something we typically do in a hospital-based practice. The primary endpoint was myocardial ischemia, and the secondary endpoint was death or MI. And what I'm showing you here on the right is perioperative death from cardiovascular causes or non-fatal MI. And there was a nearly 50% reduction for the primary endpoint and a 50% reduction for the secondary endpoint, with a number needed to treat of 20 in these patients undergoing vascular surgery receiving statin. Now, these patients required statin anyway, but it helps then to start it as far preoperatively as possible. This is vascular surgery, and it's otherwise outside of vascular surgery, there hasn't been a lot of randomized trials conducted. And these are the recommendations in the ESC guidelines. That is, we should continue statins if patients are on them, and that it's a 2A recommendation that we should initiate statin therapy in patients undergoing vascular surgery, and ideally at least 2 or more weeks before the surgery. In otherwise non-vascular, non-cardiac surgery, there's no appreciable set of randomized controlled trial data. However, this is one recent analysis, again, a large propensity score matched analysis of early perioperative statin exposed and non-exposed patients. And it was a study of about 48,000 patients, of whom 31% had received statins, and they created a matched cohort for analysis. And they showed that there was an association of statin exposure to lower rates of all-cause mortality and cardiac outcomes with a relative risk of 0.73. Now, the numbers needed to treat on both of those are high because the overall event rates in these patients are low, so the number needed to treat exceed 250 to 350. And as you look carefully at this study, you also see that, interestingly, there were many other non-cardiac outcomes, such as infectious outcomes, respiratory outcomes, renal outcomes of non-cardiac surgery that also favored the statin group, suggesting there may have been some residual confounding despite the propensity-matched approach. So at this time, while potentially it's not viewed to be potentially harmful to start statins in non-cardiac surgery of patients at risk, it is not proven in randomized trials and therefore not part of the guidelines. Lastly, aspirin. And aspirin, you can think, well, what about aspirin? Patients are on aspirin or they're not on aspirin. And you wouldn't necessarily think about starting aspirin in a patient undergoing non-cardiac surgery who's at risk, or would you? And so this is, in fact, the second POISE study. And POISE, in its acronym, stands for perioperative ischemic evaluation, study 2. And most of this work has been done, again, at Manitoba by Devereaux and colleagues. 10,000 patients who were undergoing non-cardiac surgery and they were at risk for vascular complications. They were randomized to receive aspirin or placebo with a primary hard endpoint of death or non-fatal MI. And you see the primary endpoint there on the right, again, death or non-fatal MI, but there was no benefit of aspirin in the patients in the period of non-cardiac surgery, despite the fact that there is a prothrombotic tendency of the non-cardiac surgery patient. That indeed is the physiological premise of using aspirin in a perioperative phase. But not surprisingly, there was a nearly quarter higher risk, 23% higher risk of major bleeding in the aspirin group over the first week post-surgery. And if one looks at it in more detail, for instance, looking across RCRI strata, you see here in this force plot the overall effect of aspirin versus placebo. Interestingly, in POISE 2, there were 2 strata. There was a strata of patients who either had aspirin initiated or a strata of patients who had aspirin continued. And in fact, there was neither a benefit nor a harm of continuing aspirin in terms of the primary endpoint, but nor was there any benefit or net harm seen in initiating aspirin, except there was increased bleeding across all patients on aspirin. And looking across the RCRI strata there, from 0, 1, 2, 3, and greater than or equal to 4, there was no significant effect of aspirin in these groups. So in essence, aspirin should not be initiated prior to non-cardiac surgery in a patient who's at risk, and continuation is reasonable as long as bleeding risk is also reasonable. So having gone through that, the idea of the RCRI and the fact that it's quite limited and quite old, the NSQIP, which is a newer approach but still has, although more accurate, has poor positive predictive value, and the fact that further testing or even medication management holds little to help us, I think it's time for something new. I would say that, again, these clinical risk scoring systems have high negative predictive value, but they really screen too many patients as positive. And the issue is growing. Again, there's more non-cardiac surgery, there's increasing prevalence of cardiovascular disease, and we are committed to always finding better ways to optimize our cardiovascular outcomes for our patients. So where does this lead us? If screening is not the answer, I'm here to present, I think that surveillance is the answer. So I think the opportunity is, in fact, through biomarker surveillance. And I'm going to present to you now a series of studies that have looked at the ideas of myocardial injury and non-cardiac surgery, which comes under 2 acronyms, either MINS or PMI. I'll explain what those are. And we'll go through BNP and troponin screening and monitoring in detail. And then we'll finish with a few other points about some nuances in both the treatment and the assessment and management of non-cardiac surgery and medications. So in 2012 in the JAMA, there was published a paper, again from Devereaux, in a research group called VISION, the Vascular Events in Non-Cardiac Surgery Patients Cohort Evaluation. And it looked at the idea of measuring troponins both pre-operatively and then sequentially post-operatively, looking for small increases in troponin concentration. And they titled this MINS, or myocardial injury in non-cardiac surgery. The alternative term has been more recently in the literature, or that's emerged in the literature, is PMI, perioperative myocardial injury. And basically what the VISION studies found in 15,000 patients was that elevated troponin predicts short-term mortality after surgery. The overall prevalence of a above threshold troponin was 11.6%. So it's about 1 in 9 patients. In the adjusted hazard ratios for mortality at 30 days was as high as 10.5. And you see here on the right graph that, in fact, there was a graded relationship. That is, the higher the troponin, again, less than 0.01, 0.02, 0.03 to 0.3, or greater than 0.3, the higher the risk. I'll point out there was a very high negative predictive value. That is, in the 88% of patients without an elevated troponin, the risk for an event was exceedingly low. And the net reclassification improvement over the RCRI was 25%, a significant improvement in risk classification. This is the first study that suggested this idea of surveillance of patients post non-cardiac surgery might be informing us as to who was at risk for short-term adverse outcomes. Investigators have latched onto this, and this data comes from Basel, Switzerland, and was a cohort of 2,400 patients that took the same idea, cardiac troponin T, and screened patients over the age of 65, or if they were over 45 with at least CAD or PAD or stroke. So they tried to get an older or an at-risk population with prevalent cardiovascular disease. And then they did the same thing. They measured plasma cardiac troponin T. They measured them before surgery and then on postoperative days 1 and 2. They defined an elevated, this is the study that coined the term PMI, and they found the prevalence of PMI was 16%, so a little higher than vision. It was 11.6%, but in the same range. This is being in about 1 in 6 patients. The adjusted hazard ratio for 30-day mortality was 2.7, and as you see here on the right, persisted out to 1 year time. So first you see the 30-day graph, and on the far right in the red is the patients with PMI out to 1 year. This was interesting because they then looked at what's the source of this troponin. Was it triggered by a cardiac problem, or was there an apparent clinical extracardiac trigger for this troponin association? And they in fact showed that the risk for mortality was particularly high. It was high in both cardiac and extracardiac triggers for PMI, was particularly high with an extracardiac trigger. And you see here the 30-day in the table, the 30-day mortality adjusted risks, PMI 2.7, and it's similar for mortality. It's a similar range as seen with sepsis and stroke and pneumonia. Interestingly, they look again out to 1 year, and the mortality, if you have an extracardiac cause of PMI, is approaching 40% at 1 year. And that there were worse outcomes if the extracardiac illness, again, was determined to cause this. They then showed this, which is that there's actually a continuous relationship. Rather than thinking about a threshold, in fact, you see here for the absolute values on the left for 30-day mortality and the maximum troponin observed, that the higher the maximum troponin, the worse the outcomes, and that there's a threshold which they set at 15 nanograms per liter, above which there was a high enough risk for adverse cardiac outcomes in 30-day mortality to trigger cardiac consultation, providing some guidance at what we should be telling our consulting physicians in terms of when they should call us or what we should recommend for when we should be called back. So in terms of troponin and non-cardiac surgery, screening is done as a daily troponin, both preoperatively and for the 2 to 3 days post-op. Higher risk is seen. Higher risk patients are the target patients who are over the age of 65 or younger with known ASCVD, and the incidence being about 1 in 6 to 1 in 9. Interestingly, the presentation of these patients is not helpful. Few have chest pain. Few have any potential ischemic symptoms. And again, a 6-fold increase in 30-day mortality that persists to a year, continuously graded, and driven by both cardiac and non-cardiac triggers. This really falls under the idea of the type 2 MI, right? This is the fourth universal definition of MI, elevated troponins, and whether that's driven by a type 1 MI, a type 2 MI, in patients with acute myocardial injury or these chronic myocardial injuries with elevated troponin. And that's why one needs to both measure a preoperative troponin and then surveil with troponin postoperatively. What's interesting about the type 2 MI is shown here, and this is I think an insightful analysis from Circulation 2 years ago, type 2 MI. And we often hear, you'll see on the consult service around, oh, it was a demand ischemia event, nothing to worry about. And in fact, I think this is I think overlooking an event for this patient and their outcome, or patients and their outcomes. What you're seeing here is the outcomes over 5 years and the cumulative incidence of major adverse cardiovascular events in the left and non-cardiovascular death for type 1 MIs in the red, type 2 MIs in the green, and myocardial injury in the blue. And you can see that the outcomes for myocardial injury versus a type 2 MI are the same as a type 1 MI. But in fact, non-cardiovascular death rates are in fact much higher for type 2 and myocardial injuries than they are for type 1 MIs. And survival free from any cause of death is in fact, again, much worse for type 2 MIs and myocardial injury. And what's interesting to me in particular is if you look at this table to the right, and there's 3 columns of relevance, type 1 MI, and then type 2 MI with known CAD, or type 2 MI without known CAD, is in fact that we treat these patients with type 2 MIs much differently than type 1 MIs, despite the fact that the overall cardiac outcomes are equivalent. And you can see here the rates of aspirin use, beta blockers, ACE inhibitors, statins, simply strikingly lower across for these type 2 MIs, when in fact the outcomes would be arguing that we should be treating them much more aggressively. And so this gets to the point that if you're going to measure troponins in the perioperative phase, for screening for PMI or MINS to detect patients at short and long-term risk for adverse cardiovascular and total outcomes, we should alter their treatment towards the typical patient with MI, as these patients are having type 2 MIs just of having been triggered from a perioperative as a perioperative event from a non-cardiac surgery. Yeah, I've been watching this literature closely, and I became particularly interested when this study came out, again by Devereaux, called the MANAGE study. And it's been subsequently published. We reviewed it in Journal Club maybe a year ago. We had a really good discussion about it. And it took patients with MINS, and it randomized them to either dabigatran or placebo, with the idea being that if this is a prothrombotic tendency and something's happening in this patient in the perioperative phase, we should manage them with anticoagulants. And so it randomized patients to dabigatran or placebo and showed, in fact, a lower event risk of 4% absolute risk reduction for the dabigatran group when administered at a dose of 110 milligrams BID. Now, there's some caveats here. The trial was terminated early. There was a lot of drug discontinuation. It wasn't a perfect study. And so I don't at this time would recommend the use of dabigatran for this use. But it is pointing to the fact, as I made in the prior slide, on the way we treat these patients with type 2 MI, we're missing opportunities to treat these patients. And if we're going to surveil, we've got to commit to treat. And this is one study that actually focused on these patients with a defined antithrombotic therapy approach and seemed to show a difference, although I would say that this study is not definitive. Well, it's not just troponin. And over the years, it's interesting. These studies go back into the middle of the last decade, 2006. BNP has been looked at for the same reason, and this is a meta-analysis that was published on the question: is preoperative and terminal BNP or BNP an independent predictor of 30-day outcomes of non-cardiac surgery? And the answer is yes, as summarized here. And I'll show you here the outcomes, is that the overall event rates in terms of adjusted odds ratio, you see there at the third column from the right, the adjusted odds ratio are significantly higher for patients who have elevated BNP in the perioperative phase. I think the most useful study I've seen on this actually is just recently published in January. So I'm just going to highlight this one rather than the older data. And this is actually a nested cohort study from the VISION study, that first study that published on MINS and troponin T. It was 10,400 patients age 45 or older having inpatient non-cardiac surgery. And what it showed is that preoperative, so a single preoperative NT-BNP, and NT-BNP is our assay in this hospital, was strongly associated with both 30-day all-cause mortality and the relative risk for vascular death or the occurrence of MINS. And this is where this becomes important. And so they screened patients with BNP, and if BNP was low, and you see this in the graph at the right, below 100 picograms per milliliter, there was a very low risk of 30-day MINS or vascular death. Whereas at higher levels of BNP, screened preoperatively, and this is not in patients with heart failure or that you would expect to have an elevated BNP, there was a graded relationship to outcomes, such that what they do is in the 2017 Canadian Cardiovascular Society guidelines on cardiac risk management. And so these are guidelines which are now published 3 years after the latest ESC guidelines and after the latest AHA-ACC guidelines. They recommend the following approach: that they take patients that are 45 years or older or undergoing non-cardiac surgery. And if it's elective, and this is what you see to the far right, they get a pre-op assessment with an RCRI or NSQIP. And if they're over age 65 or they've got at least an RCRI of 1, they order a BNP. And if the BNP is negative, they go to surgery. And if the BNP is abnormal, they will then measure daily troponins for the first 3 days with collaborative management of this patient. Again, for the 1 in 6 or 7 that will turn out to have a positive troponin. Now, the upside is you've seen all these patients as a consultant. This tells you the 5 or 6 you don't have to worry about. It does tell you the 1 in 6 or 7 you do have to worry about. So this is how I would summarize this. That is that we should really switch from risk assessment to surveillance. And we need to skip all the fancy stress testing and everything that's done and simply take a biomarker approach to this problem with preoperative BNP and then perioperative troponins for the first 2 to 3 days. And then when abnormal, and this is an area where we have to act a little bit on faith, but I think the type 2 MI data point us in this direction, manage point us in this direction. And frankly, the opportunity, which we all know are often untaken to manage cardiac risk factors, is an opportunity to manage risk factors, take that patient who's positive and think about the need for further testing in much more of a targeted population, and then consider how you want to manage their anticoagulation strategy. In finishing, I want to go through a few quick things just as cautionary tales for our populations for MHVI. We see a lot of aortic stenosis. It's throughout this hospital. When I was in training and early in my career, AS in the Goldman Index was only if symptomatic and only if severe. Well, that actually is not so true anymore. And I want to just a cautionary tale that some things are not in the RCRI and some things are not in the NSQIP, yet they are enriched in our population and we should look for them because they carry risk. So this is where you've got to go beyond that risk index and do some independent thinking. This is a propensity matched cohort analysis from Cleveland Clinic, looking at over 600 patients with moderate and severe AS and looking at the types of surgery they had and then the 30-day risk for MI and mortality. And what they show here is, I think, some things that are important. First of all, and you see it in the graph to the right, first of all, in low-risk surgery seen in the far left cluster, severe AS is not necessarily a safe thing, even in low-risk surgery. Now, that low-risk surgery might be important for the patient, but low-risk surgery with the patient of AS is not simply a go ahead, don't pass go, or pass go and collect your $200. This is a stop and think about the patient with AS undergoing low surgery. Surgery generally goes straight to surgery. AS is a time in which I would be cautious, particularly when AS is severe. Second point is seen in the middle cluster. The patient with moderate AS, something which we typically do not pay a lot of attention to because it's not a focus of therapy, such as TAVR, and patients are often asymptomatic, actually has higher risk of non-cardiac surgery than the patient without AS. And lastly, even in high-risk surgery, moderate AS, as you see in the far right cluster, is a significant risk for adverse outcomes. So beware the patient with moderate AS. They're in our facilities, they're prevalent, and even low-risk surgeries in the AS patient can be risky. And a cautious approach to those patients and some game planning and discussion with the surgical team and the anesthesia team can be useful. Lastly is pulmonary hypertension. Thanks to all Chris's good work on pulmonary hypertension and that of our advanced heart failure team, we have, and because of the amount of heart failure in this hospital, we have a lot of pulmonary hypertension. And occult pulmonary hypertension creates a high perioperative risk for anesthesia and intubation. PAH defined as mean PA pressure is more than 20, has a 4 to 6-fold higher mortality. And again, this is not in the RCRI, it's not in the NSQIP. So I simply say beware the patient with pulmonary hypertension if you're seeing them preoperatively, and if it's known on a prior cardiac ultrasound or known in the patient's history, please be cautious. Lastly, to anticoagulation, and I want to just talk briefly about bridging and DOACs, and then DAPT. Bridging, as you know from the BRIDGE trial, is not particularly useful in the setting of atrial fibrillation, with the provisos that in the BRIDGE trial, I think we're all familiar with this, that there was more bleeding with bridging. There were not fewer outcomes with bridging, although the caveat here being there were few patients with high CHA2DS2-VASc scores, and patients with prior cardiac embolism were excluded, as were mechanical heart valves. So bridging is something we have to think carefully about, because the bleeding risk far outweighs the benefit, particularly in low CHA2DS2-VASc patients and other patients that don't have mechanical heart valves. But many patients these days are on DOACs, and we've got to advise the teams how to manage that. Complicated algorithm, but I'm going to point you right to the middle on when to stop DOACs. That factor Xa inhibitors, the apixaban, rivaroxaban, edoxaban, should be stopped for low-risk surgery, 24 hours, and for higher-risk surgeries with higher risk of bleeding, at least 2 days before. And then a decision on whether prophylactic therapy or bridging has to be made independently, patient by patient. Lastly is DAPT and stenting. And I want to just bring this up. I would defer greatly to Lowell and his team's expertise. Always a good opportunity to have a conversation with the interventionist to put in the stent as to what you think you should do to manage it perioperatively. But 2 points to make, and then we'll move to questions. The first is that this is a large retrospective cohort analysis from the VA system in which they looked at 24 months of adverse events under patients undergoing non-cardiac following non-cardiac surgery, and when they occur. And in the solid line is bare metal stents, in the solid line is drug-eluting stents, and in the dashed line is bare metal stents. And this is data dating going up through 2010, and is traditionally held that bare metal stents are safer for short term. In fact, that's not really the case, and that it's stenting in general that creates some short-term risk for the patient. And this in this table at the right, which I won't take the time to go through, makes the point that practice is all over the place. And in fact, there's no clear trend at when and how to discontinue DAPT, whether to continue or discontinue, whether to stop one, the other, both. It does not track the outcomes. The thing that's really helped is the fact that newer stent generations are leading to shorter DAPT durations, and that in general, we're leading to the fact that with these newer stent generations, shorter term DAPT is needed, and patients can be stopped. The DAPT can be discontinued so patients can undergo non-cardiac surgery safely. And I do want to just take a moment to point out this graph to the right, the bottom right, which makes the point that in the top 2 lines are patients with a drug-eluting stent in the last month, or those with ischemic heart disease who haven't been stented. And in fact, both are at high risk for 30-day mortality. In other words, the stent only drives a small fraction of the outcomes out to a month. Most of the outcomes at a month are driven by the non-stent comorbidities. And all those other lines there are patients with or without stenting, anywhere from 1 month or greater, or 2 months out to a year. And in fact, really no difference of outcomes in patients without recent stenting, in patients with ischemic heart disease. So while we're really cautious around stenting, and it's a good conversation to have, and we have to think about what to do with DAPT in non-cardiac surgery, it's more the comorbidities of the patient than it is the DAPT and the stent that are the concern. And so close partnership and discussion with the interventional team is useful in these patients. So in the interest of time, I'm going to skip this case, but I'm going to simply come to my conclusions. And that is that the use of both the RCR and NSQIP for your perioperative risk assessments is recommended, and I think they're complementary. That said, they each have misgivings and shortcomings, and I would be using these, and I would be extremely conservative with any additional testing preoperatively, including stress testing and revascularization, absent an independent reason to do that. I do think we have opportunities with medical management in the preoperative phase As I've shown you, in the high RCRI patient, beta blockers started far enough preoperatively, there might be an opportunity. Statins, particularly for vascular patients, look for opportunities for statin use in general. Aspirin is neither to be initiated nor discontinued unless the surgery bleeding risk warrants discontinuation. And we've just recently talked about DAPs and other anticoagulants. In our system, be on the lookout for patients with obstructive lesions, particularly AS and PH. Those aren't in the risk calculators, and they'll burn us if we don't look for them. And lastly, and hopefully, and most importantly, I want to push us as a team to more proactively manage these patients in the perioperative phase with biomarker surveillance. The data are trending this way. The Canadian guidelines point this way. Our own national and European guidelines have not been updated to include this data yet. But I would say that if you're going to follow Canadian guidelines, it's BNP testing preoperatively, and then a decision to whether you enroll patients in a MINS monitoring approach, advising the team to draw troponins both pre and post-operatively for the first several days. And overall, these are at-risk patients, and we want to be aware of these type 2 MIs. They are at-risk patients, and we've got opportunities to treat them more fully for their cardiovascular risk. I want to thank you, again, thank you for everything you're doing at this time. I'm so appreciative and proud, and I hope this has been a useful respite from all that, but also brought some new information to you on how we approach preoperative risk stratification of the non-cardiac surgical patient as a team in MHVI. Thank you very much.
Excellent, Alan. That was great talk and a great summary of the data. Open it up for questions or comments from the group.
So, Gabby, Alan, this is Stu. Again, Alan, thank you very much. And of course, my personal thanks to everybody for what they're doing. So it would appear that, the notion of medical clearance, cardiovascular clearance for general surgery, which has sort of been something that's part of the lexicon and what we've done for years and years. The bottom line, in a way, is that in patients who do not have clinically evident unstable disease, the risk of a perioperative event is low, but also unpredictable. And so in a way, we get back to what Steve Epstein has said over and over again, is that we have to confess our impotence in being able to predict the presence or the occurrence of near-term cardiovascular events. And once again, sort of routine testing, again, in patients who have no signs or symptoms of unstable cardiac disease has very little value, which is, and I think we've all kind of come to understand that. A lot of education is going to have to be expended towards our surgical colleagues and those who want to be able to do their procedures having been both extremely prudent and reducing the risk of those procedures. So it's very useful talk, and again, I appreciate it. But we're going to have to do a fair amount of education outside of our own cluster here.
Yeah. I think we got to this point of nihilism where we realize there are a certain risk, and maybe you do some testing, maybe you don't preoperatively, but you sort of like, well, just good luck. And I think this is extending surveillance, replacing surveillance with nihilism, or or stumbling into things, and in the fact that the majority of patients don't have these biomarker abnormalities post-op, they can be moved fairly safely and quickly through the system, and it really hones in on the minority that do. So I think it's a productive way to approach these patients, and actually advise with good contingency plans around these patients in your preoperative risk assessment as to what to do, what to look for, when to call me back.
Other comments or questions? Alan, if you go ahead. Sorry.
I've got a question. It's Lakshmi. Dr. Taylor, I think one of the things that we struggle with in the older patients who are sort of less functional at baseline, but may have 1 or 2 or 3 of these risk factors or criteria, is that they may self-report a baseline functional status that isn't that great, but when you actually put them on the treadmill, it's okay. Do you have any tips, or how do you approach those patients when they're not super active at baseline, trying to figure out who really needs an evaluation and who doesn't, if they can't self-report a good functional status?
Right. The METS study really looked at this and just really cast doubt on our ability to even, detect those patients. And if you look in the METS study and you look at actually like for instance, those preoperative BNP levels, they're all over the place. And so I really think that, while one can be reassured by a patient that's quite functional, and the less functional patient, I think, is one that gets a lot of indiscriminate preoperative stress testing. A lot of things are found that don't necessarily mean much, particularly if you look at the context of the COURAGE study or the ischemia study on what revascularization therapies can do. And I think I'm not trying to incite that discussion, but really, what revascularization does for that asymptomatic patient. I think that the idea there is, I think that's the patient, I think, Lakshmi, that needs this biomarker surveillance more than anybody. Is a BNP, and if normal, they go to surgery without any further testing. If abnormal, they get MINS monitoring with daily troponins, and then with triggers to call back for reconsultation or reevaluation when they're positive. I think that's the most productive way. Now, can I tell you that that's been tested against, in a randomized trial against a standard of care approach? No, and I don't know if such a trial would be done. It would be interesting for sure. But my advice for that patient, Lakshmi, would be to, pay attention to functional status. We know that reported functional status does have some relationship when good. In the low functional status patient, I think that's the patient that precisely needs this biomarker surveillance.
And is it fair to say that in the absence of subjective complaints in that person, you will take a more conservative approach, so you're not routinely stressing all of these people?
No, I think I think that is something which should go by the wayside.
Okay. All right. Thank you.
Thanks. Ron, you have your hand up.
Yeah, I just wanted to, again, reiterate that in the world that we believe in randomized clinical trials, this is almost impossible to do it in this arena, and that's one of the issues that we don't have a good data to rely on other than those registries and scoring systems that most of them has not been fully validated. And that opens the field to a lot of attempts from different industry to pitch in and try to do routine treatment like balloon pump for very aggressive surgeries, or in the case of pharma, to give everyone ticagrelor and to address less events in the future. But I'm not sure how to get out of this without randomized clinical trials, which will not going to happen. So I don't know if you have any idea.
Yeah, I think it's a great point. Managed was that idea to try to at least throw some, an antithrombotics therapy. I'd like to see. Yeah, I'd like to see. I think what the problem is that the positive predictive value of any of these things is so low, and the event rates are so low. It's very hard to do studies because to find a benefit of any therapy when only 2% are having the outcome of interest to start with, a 3% in the total in all comers. It's very difficult. I think, in the future, hopefully we'll see, dedicated trials of strategies of management of patients that are biomarker positive, so that we can know what to recommend with more confidence.
Thank you.
Let me just ask the group, some people from the VA. I see we have people from Baltimore. Are people doing biomarker testing post MI for surveillance, or following these guidelines, or this new data? What's happening out there currently? All right. I think
What I would say from my experience, and I've been recommending this, people that are fellows that are around me on the consult service are probably nodding their heads at, oh yeah, just tailored. That's a Taylor thing. I think I think it's productive, but I don't think it's being done much at all. In part, it hasn't penetrated the U.S. guidelines yet because none of the U.S. guidelines have been revised since most of this data became available. It would seem a good topic for a focus update of the ESC or the AHA guidelines. The ESC guidelines from 2014 touch on it, but the data was very early. Vision was the only study that was really out at the time. And when I talk to surgeons about what to do, and I did this just, in fact, last week in a patient who underwent, underwent surgery, they instructed them to do this troponin monitoring. It's often the first time they've heard about it themselves, and they're the ones doing. They're the end user in a sense, in that they're the ones doing the. Doing the surgeries. And I would say when preparing this, I was at a cardiovascular symposium down of community cardiovascular providers down in Fredericksburg, about 250 people, and it was by a show of hands, no one was doing this in the audience, and so that's my anecdotal experience, Gabby.
Yeah, no, I think that one of the important things is if we do this, and I think you showed this nicely, is you have to have a very good idea of what you're going to do with the results. I think one of the fears that people lead to further unnecessary testing, catheterizations, revascularization, potentially changes in length of stay, all of those types of things. So you need to have a very good protocol as to what you will do with these positive results, how you'll deal with them to improve the patient outcome and keep everything else sort of moving forward correctly.
Yeah, I like the cardiac CT approach in these patients. If you think you've got to look for something, because it's non-invasive, it can be done. Often you'll pick up other things that are important. That'll pick up the odd PE and that sometimes show up in this way. And again, it can be really quick for patients and avoid invasive tests after cardiac surgery.
Absolutely. We have a comment in the chat from Jared. Alan, isn't it true that half of the adverse events and half of the mortality in the vision trial were due to non-cardiovascular causes? If so, how does this imply for treatment of these troponin positive patients?
Yeah, it's a good question, Jared. Clearly also in the Circ paper, right, the extracardiac cause of the troponin elevation is particularly risky for patients, but more have a cardiac trigger than an extracardiac trigger. I think that's feedback to the cardiac surgical team. Hey, you've got a patient at risk for an adverse outcome. I don't see anything cardiac going on here, but you've got a patient at risk. Think about what else is going on with this patient. So I think just like the NSQIP, Jared, you see that risk is not all risk is not cardiac. And so, if we worry about our outcomes as a composite, our overall health system outcomes, I think this is identifying a patient who's often not just in need of a cardiac intervention or a problem, but that's in fact struggling overall. We've seen with this COVID experience, right? These patients with elevated this tremendous, inflammatory burden, which is part of it's an extreme exaggeration of what happens in the patient non-cardiac surgery. They're having all these troponin elevations, and it's a marker for risk. It's sort of the same thing. Microcosm, they're prothrombotic. And we're seeing it to this extreme. So it's maybe not always cardiac, the focus of the closer scrutiny on the patient, but overall, because either way they're at risk for adverse outcomes. So I think it's looking at the net outcomes. I think that we are doing here, not just the cardiac outcomes. Thanks, Jared. Good question. And visions, I think, is a really important study for people to look at.
Great. Well, thanks so much, Alan. That was a great review. We tried to record this, so hopefully we will make this available later on the web. And look forward to seeing everybody next week.
Thank you, everybody. Stay strong.